Good day and welcome to the last installment of the video podcast series. That went quick, didn't it? In this last installment, we'll be considering a posterior leg and sole of the foot to finish off our journey through the lower limb and the unit as a whole. It's a nice, fairly short lecture, about 26-27 minutes in length, so hopefully it's been an enjoyable experience for you. Our last set of objectives for the unit. We'll start by looking at the popliteal fossa that lies posterior to the knee and consider its contents. We'll then dive into the posterior compartment, which was introduced in the last session, as well as the plantar surface of the foot, and consider the origin, insertion, and actions of the muscles in this region. We return to the neurovascular structures as well found within this region, and see how they are associated with the previously identified muscular components. We'll then finish off with a discussion of the natural arches found within the foot. We start with the popliteal fossa. This is a diamond-shaped region found posterior to the knee that is similar in appearance to the cubital fossa found anterior to the elbow. Also similar to the cubital fossa, it provides protection to a number of neurovascular structures moving between the thigh and leg. The borders of the popliteal fossa are the semimembranosus muscle superomedially, the biceps femoris muscle superolaterally, and the medial and lateral heads of the gastrocnemius infromedially and infrolaterally. The floor of the fossa is made up of the femur superiorly and the tibia and popliteus muscle inferiorly. It's covered by a dense, thick fascia that does not allow for expansion. Thus, any sort of swelling in this compartment, either from a tumor or abscess, tends to project superiorly or inferiorly rather than externally. Removing some of the superficial boundaries gives us a better view of the internal structures. The inferior limits of the sciatic nerve can typically be found in the superficial portion of this space, prior to their split into their terminal branches. The tibial nerve portion is centrally located and provides motor branches to the muscles in the superficial group of the posterior compartment in this region, as well as sensory branches to the knee and the medial sural nerve. It then passes into the posterior compartment just deep to the transverse intermuscular septum, which divides the superficial and deep components of the posterior compartment. The common fibular nerve portion of the sciatic nerve maintains contact with the biceps femoris muscle, providing motor innervation to the short head. It then emerges superficially from the lateral tip of the popliteal fossa to wrap around the neck of the fibula, giving off the lateral sural nerve before entering the lateral compartment of the leg. This is the point at which it branches into superficial and deep branches. The continuation of the popliteal artery lies centrally in the compartment, deep to the tibial nerve. Their close approximation results in referred pain in the case of a popliteal artery aneurysm due to the pressure on the tibial nerve. The four principal branches off the popliteal artery are the genicular arteries, the superior medial and lateral, as well as the inferior medial and lateral branches. They form anastomoses around the patella anteriorly, as well as with the descending branch of the lateral femoral circumflex and the descending genicular artery off the femoral. This anastomotic network works similar to that around the elbow. When the knee is at a flex position, blood flow through the popliteal artery is compromised. Flow can be temporarily rerouted around the bend through the genicular circulation. Note that the anastomosis is along the peripheral border of the patella to prevent damage to these vessels anytime someone scrapes their knee. In addition to the genicular branches, the popliteal artery also gives off numerous muscular branches in this region before diving into the posterior compartment to branch into the anterior and posterior tibial artery. As usually observed, the popliteal vein runs with the artery, receiving branches coursing with the arteries of complementary names. It also receives the small saphenous vein from cutaneous circulation. The popliteal vein tends to have an extensive collection of valves due to its size and the gravitational pull on blood in this region. One final note on the lymphatics in this region. Recall that the lymph vessels from the posterolateral leg drain with the small saphenous vein into the popliteal region. These superficial vessels drain into a collection of superficial popliteal nodes, while a collection of deep popliteal lymph nodes drains lymphatically from the muscular compartments. They all collect together to drain into the deep inguinal lymph nodes in the femoral triangle. Before we start with the superficial and deep compartments, we need to discuss a deep muscle that's a bit of an outlier, literally and figuratively. The popliteus sits outside the true deep compartment and acts on the knee rather than the ankle. It originates off the lateral epicondyle of the femur, running infromedially to insert on the posterolateral surface of the proximal tibia. In the previous class, we discussed the screwing home mechanism of lateral rotation of the tibia on the femur. In order to initiate knee flexion, the knee must first unlock through medial rotation of the tibia. This, then, is the principal role of the popliteus. Instances of popliteal tendinitis can result in pain over the lateral surface of the femur during unlocking and a reluctance to fully extend the knee when walking. We'll take a look at the superficial compartment first. All three muscles insert on the calcaneus through the calcaneal tendon, or more commonly the Achilles tendon. Because of this arrangement, they are sometimes referred to as the triceps surae muscle. This powerful muscle group is responsible for more than 90% of the force in powerful plantar flexion. They receive their innervation from the tibial nerve and their vascular supply through the posterior tibial artery. Superficially, we see the gastrocnemius muscle. Its prominent muscle bellies and distinct myotendinous junction make it easy to identify superficially, in particularly when plantar flexed. This bulging appearance accounts for its name. Gastrocnemius means the stomach of the leg in Latin. The muscle has distinct medial and lateral heads originating posterior superiorly to the articular surfaces of the medial and lateral femoral condyles, respectively. It generates the superficial portion of the calcaneal tendon inserting on the calcaneal bone. Its primary role is as a powerful flexor of the ankle. As it is a two-joint muscle, however, it can also have an effect on the knee joint, in particular when the ankle is dorsiflexed to take up slack in the tendon. Deep to the gastrocnemius is the soleus, the Latin term for sandal, which describes its shape. It has a rather broad origin off the posterior surface of the tibia that arches over towards the fibula. It bridges over the interosseous space at a region called the soleal arch, which allows for passage of the neurovascular bundle into the space between superficial and deep compartments. Distally, it fuses early on with the gastrocnemius to form the Achilles tendon inserting on the calcaneal bone. It also contracts to produce plantar flexion, but as it doesn't cross the knee, it has no effect on this joint. While gastrocnemius is almost exclusively activated for forceful contractions, soleus is also active in normal standing to maintain balance and walking for propulsion. It's therefore considered the workhorse of the compartment. One final, somewhat odd muscle is left to discuss. This is the plantaris, a small round muscle that originates from just superior and medial to the gastrocnemius. What makes it unique is its long, slender tendon that runs inferomedially between the gastrocnemius and soleus to insert into the Achilles tendon. Its appearance has resulted in the nickname first-year nerve, due to the tendency for inexperienced anatomy students to mistake this tendon for a nerve. Because of its small size and the high density of muscle spindles, it's thought to play more of a role as a proprioceptive stretch reflex than in force generation. This brings us to the deep compartment. In contrast to the superficial compartment, which can expand into the looser fitting crural fascia, the deep compartment is encased by the tight, fibrous transverse intermuscular septum posteriorly and interosseous membrane anteriorly. As there is little room for expansion, swelling can result in a posterior compartment syndrome, restricting blood flow to the plantar surface of the foot. We discuss three muscles here, which contribute to the principal function of the compartment: plantar flexion and inversion at the ankle. Entering the true posterior compartment, we start with the tibialis posterior. Tibialis posterior lies centrally in the compartment. It originates off the interosseous membrane and adjacent portions of the posterior surface of the tibia and fibula. The tendon runs medially to pass posterior to the medial malleolus, deep to the flexor retinaculum, and has a rather extensive insertion on the navicular, cuneiform, and first four metatarsal bones. This muscle is comparable to the flexor carpi muscles in the forearm and is exclusively involved with plantar flexion and inversion. Medial to tibialis posterior is flexor digitorum longus. It originates off the posterior surface of the medial tibial shaft and once again passes under the flexor retinaculum of the ankle to insert on digits 2 through 4 in the foot. In many respects, its structure and function is similar to the flexor digitorum profundus that we saw in the forearm. In addition to plantar flexion and inversion, it contributes to flexions of digits 2 through 5 in the foot. The final muscle to identify is flexor hallucis longus, the lateral most of the posterior compartment. The muscle originates off the posterior surface of the fibula, passing deep to the space behind the flexor retinaculum to insert on the distal hallux or great toe. It's comparable to the flexor pollicis longus in the forearm and contributes to flexion of the great toe, in addition to plantar flexion and inversion. Another role played by flexor hallucis longus stems from the route of its tendon passing inferior to the subsentaculum tali on the calcaneus. When the muscle contracts, the subsentaculum tali acts as a pulley, directing the line of pull superiorly from behind it. This provides a lift to the subsentaculum tali and consequently the lower limb, providing thrust during the toe-off phase of walking or running. We've already discussed the neurovascular supply to the posterior compartment, but now put it into context relative to the muscles we just discussed. The posterior tibial artery was one of the two branches stemming from the popliteal artery, just past the soleal arch. It then gives off the fibular artery and the two diverge. The posterior tibial artery passes between flexor digitorum longus and tibialis posterior, while the fibular artery travels between the tibialis posterior and flexor hallucis longus. Each branches extensively to supply both superficial and deep compartments. While the fibular artery terminates with anastomoses around the lateral malleolus of the ankle, the posterior tibial artery continues deep to the flexor retinaculum and into the plantar surface of the foot. We'll pick it up where we left off here later in the session. The tibial nerve travels with posterior tibial artery, providing motor branches to all muscles in the posterior compartment. It also continues into the foot and will be revisited later on. Looking at the arrangement of tendons and neurovascular bundles crossing the medial malleolus at the ankle, we see an unusual combination. First, notice that the tibialis posterior passes underneath flexor digitorum, and that flexor hallucis longus is completely separated from the other two by the neurovascular bundle. Based on this arrangement, we can use the mnemonic Tom, Dick, and very nervous Harry to describe the arrangement of these structures as they pass from medial to lateral underneath the flexor retinaculum. Time to wrap things up with a discussion of the foot. The foot serves as the platform for the body when in a standing position. Much like the hand, it's highly specialized in the animal kingdom. It has a large amount of plantar surface area that conforms to most terrain due to subtle intertarsal joint motions, allowing us to stand using 2 limbs instead of 4. This isn't the only similarity between the foot and the hand. As you examine the foot, you will notice a number of similar structures and familiar names that we saw in the hand. This is because of embryological similarities between the structures that are modified depending on the limb region. In the case of the foot, the intrinsic muscles help us to maintain balance, make subtle adjustments to our gait, and maximize propulsion during running activities. The superficial fascia and deep compartments of the foot are highly similar to what we saw in the hands. The superficial fascia over the dorsum of the foot is similar to that of the dorsum of the hand, loose areolar connective tissue that provides the skin with a great deal of pliability. This is the reason that bruising travels so extensively after an ankle sprain. On the plantar surface, the fascia is of variable thickness depending on local pressure differences and ground contact. The fascia around the heel, for example, is thick and contains adipose tissue for shock absorption. Its thickest point is the plantar aponeurosis, formed by dense regular connective tissue that projects from the calcaneal heel to the digital expansions. It provides an extra layer of protection to sensitive, deeper structures and supports the longitudinal arch of the foot. Microtrauma to its insertion point is associated with plantar fasciitis, which results in pain around the calcaneus and inflammation, particularly when initiating movement after long periods of rest. Again, we see invaginations of the superficial fascia, dividing the foot into numerous subcompartments. As with the hand, the central compartment contains the long digital flexor tendons, and the intrinsic muscles associated with the big toe and little toe motions are found in the medial and lateral compartments. The interosseous compartment again contains the dorsal and plantar interossei muscles. In this case, we do have a dorsal compartment not seen in the hand that contains a small group of dorsal intrinsic muscles, which we shall discuss. We can now start looking at the muscles of the foot. We can divide these up into 4 separate layers from superficial to deep. We'll start with the superficial layer, which has a common origin off the calcaneal tuberosity deep to the plantar aponeurosis. First is flexor digitorum brevis. This is found in the central compartment. It originates off the medial aspect of the tuberosity and runs superficial to the long flexor tendons of flexor digitorum longus. At this point, It generates 4 tendons that bifurcate to insert on either side of the base of the middle phalanges, similar to what we saw with flexor digitorum superficialis of the forearm. Consequently, it's responsible for flexions of digits 2 through 5 in the proximal interphalangeal joint. Next, we see adductor hallucis. This is found in the medial compartment, originating off the medial part of the tuberosity. It inserts along the medial surface of the base of the proximal phalanx of the first digit. This, as the name implies, abducts and flexes the first digit. The third muscle is abductor digiti minimi. This is found in the lateral compartment. Once again, it originates off of the calcaneal tuberosity, this time the lateral portion. It then inserts along the lateral surface of the base of the proximal phalanx of the fifth digit. Again, this is an abductor and flexor of the fifth digit. This brings us to the second plantar layer of muscles, which lies deep to the first and is entirely encased within the central compartment. First muscle to discuss is a rather unique one, quadratus plantae. It originates off of the plantar surface of the calcaneus deep to flexor digitorum brevis, but inserts on the tendon of flexor digitorum as it runs obliquely through the central compartment. Quadratus plantae plays a role in flexion of the toes, but also plays a more important role, it seems, in realignment of the pull of the flexor digitorum longus tendon. Flexor digitorum longus comes in at a bit of an angle into the foot, and so the pull of quadratus plantae tends to redirect it more posteriorly. This would correct any sort of inward rotation. Paralysis of quadratus plantae, therefore, is one of the causes of a pigeon-toed gait. Next, we have our lumbricals, very similar to what we saw in the hand, originating off the tendons of flexor digitorum longus and inserting on the extensor hood of the dorsum of the digits. As with the hand, contraction leads to flexion of the metatarsophalangeal joints and extension of the interphalangeal joints. This brings us to the third plantar layer of muscles. We first look at flexor hallucis brevis. It originates off of the cuboid and lateral cuneiform bones and inserts bilaterally on the base of the proximal phalanx. As with flexor pollicis brevis in the hand, it's a flexor of the great toe up to the metatarsophalangeal joint. Next is adductor hallucis. This actually originates as 2 separate bands. The oblique head comes off of the base of the metatarsals 2 through 4, and the transverse head off of the ligaments surrounding the metatarsophalangeal joints. It then attaches to the lateral side of the base of proximal phalanx of digit 1. This is the adductor of the great toe, similar to adductor pollicis in the hand. It also assists in maintaining the transverse arch, which we'll discuss. Third is flexor digiti minimi brevis. This originates off the base of the fifth metatarsal and inserts on the base of the proximal phalanx. As we saw with its counterpart in the hand, this is a flexor of the fifth digit up to the proximal interphalangeal joint. In our fourth plantar layer, we find our dorsal and plantar interossei once again. Again, the plantar interossei are unipennate, as we saw in the hand, while the dorsal interossei tend to be bipennate. We have 3 plantar that insert on the medial shafts of the 3rd through 5th proximal phalanges and contract to serve as adductors of the digits. Dorsal interossei, we see the 4 combination again of bipennate muscles that attach to the lateral surfaces of proximal phalanx digits 3 and 4. As with the hand, these will contract to cause abduction of the digits. The one difference we see between the hand and the foot is that the interossei attach exclusively to the proximal phalange in the foot. Remember, in the hand, these also inserted onto the dorsal hood. Therefore, in the foot, these are true abductors and adductors, but do not contribute to extension of the digits. Before we leave the plantar area of the foot, we're going to look at the neurovascular bundles, which we traced down to the ankle a little earlier. Remember that we had the posterior tibial artery and tibial nerve, which entered the foot posterior to the medial malleolus. Here they divide to give the medial plantar artery and nerves on the medial side and lateral plantar artery and nerves on the lateral side. The medial plantar nerve provides additional muscle branches to the flexor digitorum and to the first lumbrical and gives off common proper digital branches for cutaneous innervation to the skin along the medial 3.5 digits. It tends to give more cutaneous distribution and less muscular distribution when compared to the lateral branch. The lateral plantar nerve passes deep to abductor hallucis, running into the lateral compartment of the foot. The deep branch supplies all the muscles not innervated by the medial plantar nerve, and the superficial branch supplies the skin over the lateral 1.5 digits. So again, greater muscular innervation, less cutaneous distribution. The medial plantar artery is the smaller of the two terminal branches off the posterior tibial artery. It supplies the muscles of the great toe and has a similar cutaneous pattern to the medial plantar nerve. The lateral plantar artery is the larger of the two, traveling with the lateral plantar nerve and curving medially to form the largest component of the deep plantar arch. It supplies a similar distribution to the lateral plantar nerve. First, we see extensor digitorum brevis. This originates laterally off the superior surface of the calcaneus, splitting into 4 tendons that run obliquely to insert on the long extensor tendons of digits 2 through 5. These are responsible for extension of the distal interphalangeal joints of these digits. Finally, we have extensor hallucis brevis, which originates laterally off the superior surface of calcaneus and inserts on the base of the first proximal phalanx. So it is responsible for extension of the first digit up to the proximal interphalangeal joint.
Last topic for us to consider are the arches of the foot. There are a total of 3 separate arches that need consideration. First in this upper diagram is what's known as the medial longitudinal arch, formed by the calcaneus, navicular, medial cuneiform, and the first metatarsal bones. Secondly, we have the lateral longitudinal arch, formed from the calcaneus, cuboidal, and fifth metatarsal bone. The lateral arch is much shallower than the medial arch, and in a standing position might disappear entirely, as it's not uncommon for the cuboid to sag and to actually make contact with the floor. This is not typically the case with the medial arch, though, which still maintains some level of concavity even in a standing position. Here we have the transverse arch. This is a transverse cut through the distal row of tarsal bones, showing the medial, intermediate, and lateral cuneiforms as well as the cuboid. And because of their wedge-shaped appearance, they're responsible for creating this archway in a coronal plane. The importance of the arch is for redistribution of weight during foot contact with the floor, as well as a shock absorption during heel strike, and the return of elastic energy during the toe-off phase to quite literally provide a spring in your step and increase gait efficiency by decreasing the amount of energy that needs to be expended. If we look, once again, we would think of the tibia distributing the weight into the talus, and we talked about how this weight is distributed towards the calcaneus and into the ground. But there is a portion of this weight that is distributed in a standing position anteriorly through particularly the medial arch to the region known as the ball of the foot, which typically involves the tarsal metatarsal region. Now, if you look at the structure, the weight is being directed downward just anterior to where the calcaneus is in contact with the ground, and so consequently there's a tendency for this arch to want to collapse in a standing position, and it's a number of elastic structures that we see particularly along the medial longitudinal arch which absorbs this distension of the longitudinal arch, absorbs that energy, which serves a shock absorption function, and then during the toe-off phase recoils and returns that energy to foot flexion, which will assist in propulsion of the body forward. The arches are maintained in 2 ways. First, based on the bony architecture. So we look at a number of these structures have a wedge-shaped appearance to them that naturally create these arches. Most prominent in the transverse arch, where we see the wedge-shaped appearance of the 3 cuneiform bones, but also within a number of soft tissue structures. First of all, we have a number of long tendons that cross the ankle, which will give active support to the arches. Tibialis anterior and tibialis posterior help to lift on the central region of the medial arch, and as we talked about the other day, flexor hallucis longus, because of its line of pull, will be able to draw directly upwards on the sustentaculum tali that it passes underneath, giving an inferior lift to this portion of the arch. Additionally, a muscle we just talked about today, the flexor digitorum brevis, spans from the posterior to the anterior portion of the medial arch, and a slight degree of contraction will help to support this base. Finally, we have 4 distinct ligaments which will provide passive reinforcement of the lateral arch. These are the plantar fascia that we identified earlier in the class, which lies just above the flexor digitorum brevis, but also we have 3 intricate ligaments in the underside of the foot that support the arch. First is the long plantar ligament and the plantar calcaneocuboidal ligament, also known as the short plantar ligament. These both lie deep to the musculature that we just discussed and provide ligamentous support to the superior portion of this arch. Finally, we have a structure known as the plantar calcaneonavicular or spring ligament. This runs from the sustentaculum tali of the calcaneal bone to the tuberosity of the navicular bone. And if you look, just superior to this is the apex of the arch, which is formed by the head of the talus. So essentially you can think of the spring ligament as something of a hammock lying between 2 trees, the sustentaculum tali and the navicular tuberosity. And the head of the talus would represent an individual resting and sitting in that hammock, such that it provides passive support to the head of the navicular, but still allows a certain degree of elasticity within the medial longitudinal arch. Finish up by looking at the lateral aspect of the leg. We can once again see our peroneus brevis and longus tendons, which will help support the lateral longitudinal arch. But also remember that the peroneus longus tendon is transversing across to the medial aspect of the foot. So as a result, when we look at the transverse arch, if we were to extend the bony architecture beyond the medial cuneiform, we would essentially see the first metatarsal bone in this position. The peroneus longus tendon essentially is running down the lateral aspect of the foot, running across and attaching to the medial aspect, such that when this muscle contracts, it's also going to generate a compressive force that helps to maintain the longitudinal arch.
Well, that's it. That does it. End. Finite. Finito. This has been the last session. I hope it's been an enjoyable experience for you. A lot of people find the flipped classroom approach very scary at first, but tend to come around with a little bit of time. If you didn't happen to be one of those people, well, it's one of those things that you're not going to be able to appeal to every single person, but I have done my very best to try and make it a positive experience, and hopefully you'll be able to reflect upon that. So, for one last time, this has been Dr. Stuart Ingalls. Enjoy the rest of your day.